We have a large number of questions here, but there's actually one more person that we have to acknowledge that hasn't been mentioned that much today. But this whole event really couldn't have happened if it weren't for one individual, a member of our MS Center, who really has taken the lead last year and this year to put everything together, to organize the sponsors, to get this wonderful location set up, get all the meals taken care of, get all of the volunteers coordinated. And she's one of our nurse practitioners, Bethany Schreiber. So she's incredibly shy. It was all we could do to even get her name on the program at all, but I think we're going to force her to come up briefly.
Bethany, this is a small token. They're cheap at Safeway, so don't.
Thank you so much, everyone, for coming, especially so early in the morning. I think this is very meaningful for us, as well as hopefully as well for our patients and everyone in the community. Thank you.
All right, she tried to escape, but I grabbed her. You can't go away. All right, so I'm just going to be honest. We got so many questions that I'm probably just not going to be able to get to all of them, but we're going to do as many as we can. The first few are sort of softball questions for the group, okay? One was, can you provide the site again to get access for the slides presented today? And this is our website. Honestly, you could Google Georgetown MS Center and you'll get to this site. The slides and presentation should be uploaded within 2 weeks, we think, okay? I'm also going to announce that for some people who maybe aren't as comfortable with the computers or may not have access, we do have a limited number of printouts of the talk. So if you wanted a paper, we have a limited number, maybe about 100 of them. Unfortunately, Dr. Moore's talk isn't included in that one. So again, that'll all be available online, but if you really would like a hard copy, we have some of those in the back. And again, before we start, I'm going to remind you, parking vouchers, don't forget them. Okay. General question for the audience. What do you do for vitamin D intake if you're lactose intolerant? But I think also just a question about recommended dosage for vitamin D supplementation.
So for the vitamin D3 supplement, we recommend 5,000 international units a day or 50,000 international units a week. Those are both in pill form, so it shouldn't affect whether you're lactose intolerant or not. You can get it from supplements as opposed to dairy.
All right. This is another general question. This is about MRI. MRI with contrast of using gadolinium. How safe is it, especially for children? I don't know if anyone wants to tackle that.
I can take it. So MRI with contrast is very safe if you have good kidney function. I know more recently there's been some literature about how the contrast remains in the tissue. What that means clinically right now, we don't know. But for the most part, as long as you've got good kidney function, you should be able to excrete out the gadolinium, which is the dye that is given for an MRI. And the reason that we give the dye to begin with, as Susan had talked about, is to pick up any active lesions that are actively forming, either in the brain or the spinal cord. So there is some utility. And again, whether or not you get MRI, the dye with MRI or not may depend also where you are in terms of the disease and also in terms of the medications. So that's what I would say.
What about what remains in your brain?
Say that again? I'm sorry.
What remains in your brain?
I think she had a concern about if it does remain in the brain.
So there is some data now that's coming out that's indicating that the gadolinium may remain in the tissue. I think the issue that we have is that we don't know what that entails clinically. So far, our patients have done fine, and we've been using MRI with dye for, I think, a few decades now. So this is somewhat of a new finding, and I think there's still more to know or to learn about it. I don't know if any of the other attendings would have any thoughts.
So we are cautious. I think an MRI without dye, if there's one that you can compare it against previously, is really all you need. If it's a new diagnosis, then you really need the dye to understand how active things are and to make the diagnosis of MS. But once the diagnosis is established, at least this is just what I do, I really am not doing MRIs with gadolinium anymore because I don't see the purpose. I can compare it to an old MRI, and it gives me all the information I need to know if there's any new spots. And an active spot only is there for 3 weeks, and so the gadolinium is a chance that maybe you're going to see something active in that 3-week period. So, to my way of thinking, newly diagnosed patient, absolutely, we need gadolinium. After that, if it's just for monitoring, that's just what I'm doing. I am not doing gadolinium because of the concerns about the gadolinium remaining in the brain. It's a heavy metal. I don't know exactly what that means. And the cost is not insignificant. You know, an MRI now you've doubled the cost and you have double the copay. And so why do I need to do that if I don't need to? So that's just what I do. I pretty much stopped using gadolinium for follow-up MRIs.
Yeah,
Okay.
It's where you are, I think, in the stage of the disease, I think.
Right.
That's where it has utility. But I think, as Dr. T was saying, as you keep going further, you may not need dye with every single MRI that we get, so.
So the question is, how safe is it for children? And again, it's the same issue. It's a heavy metal. It remains in the brain, in the deep part of the brain. If you need it for an initial diagnosis, it is approved in pediatric population. But again, repeatedly exposing a child to gadolinium is probably not a great idea. And certainly if you have kidney problems, it's not an issue because it's a big issue because you get rid of it through your kidneys. And if you have kidney problems, it remains in your bloodstream and then it goes into the skin, and then you can develop what's called systemic sclerosis. It almost looks like the stiffening of the skin. And so clearly, this is not a benign compound.
All right, one last sort of general question has to do with the flu shot. A patient wrote, some years ago I was told not to get a flu shot due to MS. Are there different types of shots or is there any type of flu shot to avoid?
So in MS, we don't want you to have live viruses, and there was available a live virus flu vaccination. But now the flu vaccination that you would receive is not live, so we do want you to get your flu shots.
All right, so I'm going to move into specific questions that were directed at specific speakers. These questions would be directed to Dr. Tornatore. I'm going to kind of try to combine some of them, if that's okay, just in the interest of time. So I'm going to read a couple of comments. One is, how are healthcare changes going to affect care in the future? I think this is the same way. You mentioned the difficulty with healthcare these days. How do you think changes pending maybe to the ACA, Affordable Care Act, will affect future treatment? And then a question kind of just asking about how sort of the interaction between healthcare providers and this specialty model.
So healthcare policy is very fluid, and we do have great concerns, as I said at the very beginning, about where we're going to be, particularly for patients who have multiple sclerosis. We will be very strong advocates in Congress to make sure that patients who have MS have full coverage, that they have access to care, that they have access to medication. And this is going to be a very, very big push, not only from our center, but from other groups that have a strong stakehold in this. Not only us, but also patients and other organizations. We cannot be complacent. We have no idea what the healthcare law could change. Clearly, the things that we have to protect are the pre-existing condition cannot exclude you from getting insurance. That was a disaster in the past. We're past that. The rates, as far as they have to be capped. I mean, you cannot say, okay, yeah, you can get insurance, but I can't afford it because it's $2,000 or $3,000 a month. And so that we're also looking at. And then there's a lot of thinking regarding the patient-centered home. And this is why we want to be on the forefront of this, the idea that we want to develop this model. We want to go to Medicare, to the Center for Medicare Services, which I am actually going to do with several others. We've done it once. We're going to go back again later this month and tell them we think this is the model. And this is how the patients should be cared for. It should be a soup to nuts model. It's almost like Kaiser, if you will, for MS, where you get everything all in one spot, and we take care of them. And in return, rather than paying your premiums to the government, the premiums come to us, and we adopt the risk. We adopt a lot of the other issues that come with that. And we're going to do that with the private insurance companies also. And so it's a long-winded way of saying, I don't know what's coming. None of us can actually predict what's coming. But we have to be aggressive in determining what that policy is going to be ourselves. If we don't do that, if we don't have a voice at the table, we're going to be in deep, deep trouble. And I see Kevin Doherty at the back. He's one of the representatives from the National MS Society. And they have been very vocal advocates as well. But I think there has to be multiple voices coming at this idea from different angles. And a patient-centered practice is something that we're going to put out there as a different model that will grab people's attention, even if it doesn't do anything. It's going to bring the idea of MS needing specialized care, at least in some circumstances, so it will sensitize people to it. So more to come. I think the patient website that you're putting your answers in, we're going to post things in there educationally from time to time. And then we're going to try to find another way to keep in touch with everybody instead of annually so that we can all stay up on this and if we need to, reach out and advocate for each other.
All right, thank you, Dr. T. All right, this next question I think was for Dr. Osborne. I'll try to tackle it. Which disease is more severe, MS or NMO, and why? I will tell you that neuromyelitis optica, as Dr. Osborne explained, often does affect the optic nerves and can affect vision and the spinal cord. Recovery from NMO often is actually not as good as it is with MS. So in that sense, you could argue NMO is more severe for some people. Also, as we didn't touch on it that much, but there are 15 different FDA-approved drugs to treat MS, and we have 0 approved drugs to treat NMO. Dr. Osborne mentioned there are research areas and off-label things that we do. So between the two, honestly, if I had to vote, maybe NMO is more severe, but I would emphasize the point he made in his talk. The key is really to separate the two out, to get the diagnosis correct, because the way we treat those two diseases are different. All right, the next questions were for Dr. Mora for his talk, and again, I'm going to try to combine a little bit. The question was, given research on linkage between gut microbiome, do you have recommendations regarding diet changes for MS patients? Also a question about, well, would fecal transplant, we hear about that sometimes, be useful for treating MS? And I guess sort of succinctly, someone wrote, microbiome plus MS, cause, effect, or sequelae?
Thank you, Dr. Chin. As a matter of fact, I had the opportunity to read all questions related to my talk. About 15 cards were completed. We reduced it to the most important 3 that Dr. Chin just read. But in the back of one of the cards, I basically wrote the answers to all 15. And I will summarize this as much as possible in 2.5 minutes. So probiotics. I don't think that taking probiotics daily is going to be harmful. That still needs to be validated. I understand Dr. Howard Weiner's team in Boston, they are conducting a clinical trial on MS patients with probiotics, but we still need to hear from them. At the meeting in Paris last week, I didn't hear too much from them, or there was a presentation eventually, but we know that he's very active on this topic. We will hear. Now, those of you who are willing to take probiotics, I will not say be careful. I don't think it's going to be harmful, but still, we need to hear, learn from a solid report. Number 2, diets, vegan, paleo, Mediterranean, gluten-free. In general, most of you here, several of you have asked me what diet, and basically I say just avoid junk food. I mean, because this is going to destroy your cardiovascular system, Big Mac, things like that. But otherwise, I'm not really an advocate of aggressive diets like the gluten-free. I understand paleo diet demands some effort. Mediterranean sounds fancy. I really don't recommend a specific diet. I don't know if my colleagues here in the table, please, you are welcome to say.
Anything with chocolate's fine.
So let's see what comes out of research. And that goes with the continuation of the issue of the microbiome and microbiota. Are there any clinical trials? Stephen Jacobson, who is the chief of virology at the NIH MS clinic, He actually mentioned recently that in his laboratory, they already have about 200 samples feces from patients with MS. So that means they are actively working on the microbiota, on some of the patients who go to NIH. So something for sure is going to come out, because Steve, who was my mentor when I was at NIH, he pushes hard for all his fellows to publish promptly. Fecal transplantation. Any clinical trials yet? Not at Georgetown, no, not yet. And so far, we have not spoken about collecting samples for analysis of the microbiome in our patients. Maybe at some point in the future, but certainly we're paying a lot of attention to what others say about that. Apparently, in other disorders, fecal transplantation has been useful, but I believe that still in MS, we need to hear from reports. And there was a last question about vitamin A, based on my presentation, especially about the paper that was published just last week. I still feel that there should be validation. I would like to learn more about that. I share this with you because it's a new paper published just a week ago, but I would like to read more and learn more about that before officially being obsessive with vitamin A as we are with vitamin D. Let's recall, in children, if we give too much vitamin A, children may develop what we call pseudotumor cerebri, swelling of the brain. So it happens as vitamin D. If we give too much vitamin D, it may become toxic, right, leading to kidney stones. If we give too much vitamin B12, in general, we're not worried too much about that. But again, it belongs to the group of things that requires learning more and hear about validation.
All right, thank you, Dr. Mora. The next set of questions were for Susan Stewart regarding MS relapses. So, and again, I'll try to condense them. So one was a question about if you get an infection, what steps can be taken to try to reduce the risk of a relapse occurring? Another question mentioned about how, we heard that a relapse should not be caused by stress, but the question is, isn't it true that increased stress might trigger a relapse, so along with infections? And then the last part of it was really just asking for more details about the cognitive symptoms that can be seen. Are they symptoms of relapsing remitting MS or the effects of a relapse?
So that's true that infection and stress can certainly cause a relapse or worsen the symptoms that you have. So if your symptoms that you already have get worse, then the first thing we do is look at the underlying causes. And the number one would be infection, if you have a urinary tract infection or a respiratory infection. And so we would treat the infection just like anybody would, whether you had MS or not. And once the infection is treated, then the baseline symptoms should improve. We wouldn't give you steroids if you have an active infection. That would be counterproductive. And certainly if you have cognitive symptoms, those are caused by MS, and they can also be worsened if you have an infection, if you're having more stress, if you're not sleeping well, if you're having a relapse. So the cognitive symptoms can go both ways. And again, if you're having a true relapse, we treat the relapse, and the symptoms should improve. If it's a pseudo-relapse or worsening of your baseline symptoms, then we treat the underlying cause, and your symptoms should improve.
All right, thank you, Susan. All right, the next set of questions were directed for Dr. Amjad regarding spasticity. One is, I was going to combine some, but a quickie one was someone asked, what is tone? And I guess they just wanted to know what that was.
So tone is something we should normally have. Tone is the normal contraction of muscle that allows us to move, right? So it takes tone to stand. It takes tone to do everything. Spasticity, I think Lisa kind of touched on this, as a balance. And so in spasticity, it's excessive tone that wins out. So it's too much muscle contraction. It's over muscle contraction or aberrant, abnormal, uncoordinated muscle contraction. So tone is a good thing. Tone is normal. Excessive tone that's not regulated, that's not good. That's what leads to spasticity.
Okay, great, thank you. So the next set of questions I'll combine were all related to intrathecal baclofen. So one of the questions was, do baclofen pumps cause infections? Someone mentioned, I have an intrathecal baclofen pump. Sometimes I'm very tight, other times I'm very loose. Is this normal? And assuming there's a refill frequency of some type, can you speak a little bit to sort of the quantity of fluid in the pump and how complicated is it to refill the pump?
So the first question was about infection. So typically the rates of infection are fairly low, and that usually happens when the pump is first implanted. Again, we've had very good success at keeping the rates of infection low. Here at Georgetown, we have a very good neurosurgeon that will do that. Once the pump is actually in, I think the risk of infection is extremely low. It's really in that post-op period that infection may come into play. And then the second question was about
Sort of the refill, maybe what gets involved.
Okay. So the pump comes in two different sizes. It's a 20 ml pump versus a 40 ml pump. So the refill frequency will really depend on the dose that you are requiring. And again, it takes time to work up to a good dose. And also the concentration of the drug, because the drug itself will come in different concentrations. So all of that together, typically the refills can go anywhere from 90 days to up to 5.5 months. So you can really rely anywhere on that spectrum based on the dose, based on the concentration, and based on the volume of the pump.
And then the last one was just, I guess, an individual person has a pump, but was reporting some variability in whether there was more stiffness or not.
Right. So like I said, at certain times of the day, you might have more spasms, you might have more stiffness. There is an underlying rate that you will be getting of the baclofen, but we have the flexibility where we can adjust that. So maybe we can give you a little more at night, or maybe a little more when you first wake up in the morning to sort of help make things a little more level in terms of your tone.
Okay, great. So thank you, Dr. Amjad. And going along with that for Lisa Ebb, I think from the physical therapy side, this question has a couple of parts, but I think are related. When nerve impulses are interrupted, are there specific exercise or stretches that might positively influence functionality? And I think on a related note, are there alternative routes that are activated or recruited, based on mobility?
So once the nerve signal is interrupted, physical therapy is not going to change the underlying disease process. What we're here to do is improve function and mobility. So strengthening muscles that are not affected, stretching tight muscles, that we're not going to reestablish that connection, but we're going to try to maximize function with what existing muscles are functioning.
All right, great, thank you. Mm-hmm. This question is for Dr. Brown. Okay. What about MS and impotence? Quote, or parentheses, I'm asking for a friend. What other special considerations or treatments other than Viagra are available to help facilitate the physical aspect?
Sure. So lots of friends ask these questions, and that's very appropriate to a urologist. So there are 3 oral medications. There's Viagra, Levitra, and Cialis. Despite oral medications, there are other things closer to the penis. There's an intraurethral suppository, or muse, which can have a local effect on the penis to try to make it more potent. There is also injection therapy, which we teach in our office, where you inject a small amount of drug directly into the penis for rigidity and penetration. And then finally, there is an inflatable penile prosthesis, which is a surgical procedure where you basically pump it up like a Reebok pump, use it, and then can deflate the pump so that it doesn't appear as if you have an erection all the time. Historically, they used to be sort of a malleable, rigid rod, and people looked as if they had an erection under their pants. That is no longer the case. It is inflatable. So there are several mechanical type things, as well as oral medications and local injection therapy that we can go over in the office.
Great. Another question, I think you touched on this in your talk, but the question asks, how important are daily antibiotics to control urinary tract infections in MS patients?
So it's certainly patient-specific, but as I mentioned, the current guidelines actually recommend against daily prophylactic antibiotics. There are certain situations in which prophylactic antibiotics are helpful, such as a small dose after intercourse at one time, and certainly if there's an active infection, we certainly want to treat that because it can promote worsening of symptoms and things like that. If you have been on prophylactic antibiotics for a long time and are terrified to come off of them, which I see a lot, there is new evidence changing that that's not the best treatment regimen, and together we can work to try to back that down to prevent relapses and get you off the antibiotics.
Okay, thank
But
you.
typically bladder drainage is what's needed.
Great.
just-
Because, oh, sorry,
I
go
just
ahead.
want to just make a brief comment. A couple of years ago, Kevin organized a group of men, and I went and spoke to them about sexuality in MS. And the slides broke, and I said, well, we're just going to be question and answer. So 3 hours later, it was like a frat party. But your quick answer there is just the tip of the iceberg, to be fair. There's a lot more to male sexuality and female sexuality. And there are a lot of other things that, that can be done. And obviously, you all know that, too. But I just wanted to point out that I thought your summary was awesome, but boy, it's really complicated.
Actually, it is a topic that's come up before, right, for potential topics. We'll have to plan for it next year.
The pictures would be awesome, yeah.
So, all right, just because of the timing of how we went through, we didn't collect the questions for me to filter for Dr. Mitchell, but I think you have some cards. Did you want to select some questions to answer?
I feel like I should. There's actually a comment first that I wanted to share with you. We had actually the owner of the Tacoma Wellness Center was here. I'm not sure if she's still around, but she, and I was not aware of this, just wanted me to let everybody know that they will actually, once you get a referral or recommendation number from your provider, you can take that there and they will walk you through the enrollment process, which is a huge help. She said sometimes patients have had difficulty with the DC registration process, so that's for DC. Okay. I'm sorry I don't have time for all of these, but okay, so for those of us who enjoy the THC of marijuana, what is your recommendation of CBD versus THC? Can I do both? Absolutely, and some of the research and literature that I read, is that a clap? Is sometimes the ideal ratio for MS patients, depending on which symptoms you're trying to address, is actually a 1-to-1 ratio, I have heard is something. But at these dispensaries, too, they do have experts that will sit down with you as far as what your symptoms are, and there are multiple strains. There are hybrids of these plants, and they are cultivated to address specific symptoms. Let's see. Oh, God, I need my glasses. How old am I? Okay, is medical cannabis available in different dosages, and if so, how do I know what dosage is appropriate? Again, yes, absolutely, it's different. I don't want to say necessarily dosages, but it's concentrations of these chemicals, the CBD and THC, the ratios of those components. And again, I would probably refer you to the people who work at the dispensary because that is their area of expertise. Typically, with any medication, we would start you low and slow, see how you react to the medication, and then titrate up until you have a therapeutic effect. Is CBD oil available over the counter as effective for MS as medicinal cannabis? I actually don't really know the answer to that. I know there is an issue in Virginia is really, as I said, kind of behind the times as far as the legalization of marijuana. But there is legislation that just was passed over the summer that decriminalizes the possession of CBD for patients who have epilepsy. That currently is the only diagnosis.
So in Maryland, you can get CBD oil over the counter, and you can get it on Amazon. But what the Europeans have learned is that you actually need a little bit of THC if you're using it for pain and spasticity. So CBD oil alone, which you can get, is probably not going to be helpful if it's spasticity. Maybe for pain, but really you need a little bit. And as you pointed out, the receptors, the THC receptor really attaches where the CBD really doesn't.
Attached to either receptor. There was one about driving, which I thought was an interesting question. And again, so how does the use of medical marijuana impact on motor vehicle operation? And again, that would probably, you are driving under the influence of a drug, basically. So I would recommend that you not operate heavy machinery or get behind the wheel of a car while taking this, especially with any medication, you want to see how it affects you, but we don't recommend driving under the influence of medical marijuana. I'm sorry I don't have time to get to all of them, but I know that we're on a time
All
frame,
right.
so.
So in the end, we did run maybe about 15 minutes late. But so I have a couple of things. One is we're not going to throw away any of the questions we didn't get to. We think it'll be useful for us to review them and to understand, what questions we could answer for you in the future. You do have an evaluation sheet, so please fill that out. And there's an open-ended part there if there's a topic that you'd like us to address next time. I really would like to thank all of you for coming and making this event a success, and I'd really like to thank our speakers who were fantastic. All right, we'll see you next year, all right?